Good morning, everyone. I am Mark Erkin, and we are live this morning on a Tyro multidisciplinary seminar. And we are joined by truly an outstanding group this morning that proves to be both highly educational and I think very entertaining. As always, I'm going to introduce our speaker and our panelists. And as always, I encourage all of our listeners to send in any comments, questions, and I'll do my best to get to them before the end of the hour here. We're joined this morning by Dr. Marco Alvarez, who is a radiologist based in Mazatlan, Mexico. He specializes in diagnostic and interventional thyroid radiology. In 2015, he founded the annual meeting known as Thyroid Fest, which is a Latin American multidisciplinary program designed to educate physicians providing thyroid care. This year's program, if I interpreted it correctly, is scheduled for March 21st and 22nd. And looking at the program, it looked to be an extremely educational platform. This morning, I'm joined by a very frequent presenter on Tyro, Dr. Azita Khorsandi, who is my esteemed colleague at Mount Sinai Medical Center, where she is a professor of radiology, molecular biology, and interventional radiology at the Icahn School of Medicine at Mount Sinai. Dr. Khorsandi has recently been named the Mount Sinai Health System Chair of Neuroradiology and Head and Neck Radiology. Dr. Khorsandi is truly unique among radiologists with whom I have worked throughout my career, and I've had the honor of working with some very esteemed head and neck radiologists. She certainly stands out in terms of her dogged determination to obtain answers that impact the clinical course of patients with head and neck and thyroid cancers. As I was just explaining to Dr. Shaha, I will text Dr. Khorsandi 24 hours a day and 7 days a week, and she is relentless in getting an answer to my questions. And so it's truly amazing that in addition to her expertise, which is unparalleled, her commitment to the delivery of the highest quality of patient care is also very, very unparalleled. I am really thrilled to introduce Dr. Ashok Shaha. He is really perhaps one of the most promising young endocrine surgeons who has shown tremendous promise and potential in the field of thyroid surgery. In all seriousness, my colleague and friend, Dr. Shaha, is truly a model for what it is to be an academic surgeon. He has an unparalleled commitment to the education and training of medical students, residents, and fellows. And he has published a remarkable 997 scientific papers and has lectured throughout the world. I shared with Dr. Shaha that my goal in life is to be a co-author on his 1000th publication. And so I am hard at work in trying to achieve that goal. He is the recipient of numerous awards, both at the institutional, national, and international level. He has held leadership positions in regional, national, and international societies. And so, Ashok, thank you for joining us this morning, and we look forward to your comments as always. And so with that, Dr. Alvarez, if you would like to share your screen and get started, and we will join you at the very end of your presentation here.
I'm Dr. Marco Alvarez. I'm really honored to be here in this global community and very humbled to be among these panelists. Today, we're going to be seeing a pictorial essay regarding diagnostic and therapeutic approach to the lymph nodes in the patients with thyroid cancer. I am based in Mazatlan, Mexico, and I like to call myself a thyroid diagnostic and interventional radiologist. This is not a position that is really widely available in the world, but I really love thyroids, and I wish I could do everything, 100% of it, and hopefully will do soon. Okay, well, we're going to first address the elephant in the room. We're going to be talking a little bit about the issues with the global quote-unquote pandemic of thyroid cancer. We're going to be talking about the sonographic findings. I'm going to be stressing the fact that we should call the lymph nodes in the neck via ultrasound normal versus pathological. We cannot definitely call them metastasis unless there are very specific signs that we will address as well. We're also going to talk about the interventions that can be not only diagnostic, but today therapeutic. We can all say that all international protocols identify the ultrasound as the imaging method of choice for the initial evaluation of the patients with thyroid disease and thyroid cancer. Ultrasound is excellent as well in order to guide the procedures for the diagnosis, the follow-up, and many times we can do also interventions in the patients who have metastatic disease. In the recent years, perhaps in the last 10 years, there's been overdiagnosis of thyroid cancer according to several societies. And the real problem goes well beyond the overdiagnosis. The real problem goes with the overtreatment or incorrect treatment of many of these patients, which can be because incorrect treatment can be because they were not properly diagnosed at the earliest stage, or they were performed with procedures that caused them issues. Back in 2016, the World Health Organization issued this statement saying that overdiagnosis is a major driver of thyroid cancer epidemic. So, a great journal, Radiology, even published an editorial that says, is it time to turn off our machines? I think it is not time to turn off our machines. I think it is time to turn on our eyes and to truly know what is exactly that we are looking for. We're going to focus today on the lymph node and not talk particularly on the thyroid nodule. Several attempts have been made across the world in order to properly address via ultrasound the issue with thyroid nodules. We all know that in 2009, Dr. Eleonora Horvath from Chile published her first TIRADS, and then in 2011 we had Dr. Kim's version from Korea, Dr. Ross, the French TIRADS, and then they developed into the European TIRADS in a later version. In 2017, the American College of Radiology as well addressed the situation and published the TIRADS. One of the things that I have to say about TIRADS is I wish it was a system to read not only on a thyroid nodule, but on the whole gland. So it's a work in progress, and I invite everyone here to read the update, the lexicon for the eye TIRADS, which was recently published in the Journal of Radiology, and I think it's going to be a game changer. Why do I say that? Because it addresses some of the things that we need to talk about lymph nodes. Anyway, so when we're talking about a lymph node, we must understand that the lymph node has several structures that can be easily seen under ultrasound. We have a capsule in the periphery, a cortex, medulla, and a vascular hilum. If you understand the normal anatomy of a lymph node, then you will understand the pathological things that we have to see under ultrasound. Every single time that we talk about a pathological finding in ultrasound, I always tell the residents and the trainees that they have first to know what is normal. You have to see what is normal. You have to understand it, know it by heart, because once you know what is normal, then you will be able to understand when something is abnormal. For the most part, lymph nodes in the neck are ovoid, except for the ones in N1, the submaxillary ones that can be a little bit more rounded. Always, the lymph nodes, have to be hypoechoic in the periphery. They will have an echogenic hilum. That means they're going to be kind of like dark in the surrounding area and bright in the central part. They have to have a vascular hilum, which means that when you turn on the Doppler, that you will see the movement, you will see the blood vessels only in the hilum. And if you use elastography, they have to be soft. A couple of things that we also need to talk about ultrasound in the neck particularly. Yes, ultrasound, it is operator dependent. Of course, it does make a difference if the person who is performing the ultrasound has clinical knowledge of the patient, but also has the training and the experience to perform these exams. I also need to say that ultrasound is not only operator dependent, but it's also machine dependent. We live in a time where there's a rebirth of the POCUS, the point of care ultrasound, but then point of care ultrasound will use a machine that perhaps has, I don't want to say low quality, but mid-level quality. And it's not going to be the same if you do scan a patient with an entry-level ultrasound machine that with a mid-range or premium machine. So training and machine. Also, another really relevant thing that we have to say today, time makes a difference. You cannot do an ultrasound scan on the neck in 2 minutes. You have to take time. Actually, the best ultrasound scans come from the person who knows the clinical information. So it doesn't matter if you're an endocrinologist, a radiologist, or a surgeon performing the exam, you must know all the clinical info on the patient. This is the only way that you're really going to help the patient. You have to take some minutes. I know we're busy in our practices today, but it always pays. It's in the best interest of the patient that we sit down, we take a look at the notes, we take a look at the lab results, and then we scan the patients. The reggae song says, "Get up, stand up." So I truly invite everyone to get up, stand up, and go scan your own patients. Yes, I know that everyone in the US has the availability to have the ultrasound performed by a tech. And some techs, many techs, will be excellent persons performing an ultrasound, but it does pay if you do it. Particularly, I believe if I was a surgeon, I would really like to do my own ultrasound scanning just before surgery, because then I know what I'm going to be dealing with. So get up, scan. We mentioned that the lymph nodes, as I said in this pictorial essay, are going to have a hypoechoic area, an echogenic hilum, and there's going to be some blood vessels within the center of it. Sometimes people try to use that sizing as a parameter of abnormal lymph nodes, particularly in the context of thyroid cancer. I think we should go well beyond the sizing, and we should focus on the characteristics. Always remember hypoechoic in the periphery, echogenic hilum, and vascularity in the hilum, at the level of the hilum. We also mentioned that the ultrasound should, particularly when you use elastography, the lymph nodes should be soft. I have to say a couple things. There's different elastographies. We have strain elastography and we have shear wave elastography. Strain elastography is the one that you're going to be pressing the neck, this particular case, and then you're going to be seeing if the thyroid nodule deforms, and that's going to give you an image in color that, depending on the machine, is going to tell you if something is soft or hard. The other one, the shear wave elastography, pretty much you press a button, and then the machine is going to measure the speed of sound through the lymph node, and it's going to tell you from an algorithm how hard it is or how soft it is, and then you can compare it to the adjacent fat or muscle. Okay, so we're gonna advance. Another really relevant thing when we're speaking about thyroid, about neck ultrasound, one thing is to be talking about the all classical anatomy and say lymph nodes of the jugular area, lymph nodes of this and that, so maxillary. But in order to address the surgeons, we must always report by neck levels. The neck is going to have N1 submaxillary all the way to N7. which is in the upper mediastinum. I always encourage everyone. We don't want to take the time to say what is what, but some of the relevant things that we know, always look for N3, because N3 is going to be, it's the gossip area. It's always going to be one of the places where you're going to find the first lymph nodes with metastasis in thyroid cancer. Another relevant tip that I always tell the people in training, the persons in training, is you have to look for N7. N7 is not an easy area to look for, because you have to go through the sternum in this particular area. And then what you can do, as usual, you're going to be using your linear probe, but you need to decrease the frequency. Once you decrease the frequency, then you will be able to have a better look at it. And sometimes we even have to use some other transducers. We put a cup on the endocavitary probe and look through the neck, kind of like this. Anyway, please make sure that you read. Throughout the lecture, you're going to be seeing some images. That these are articles that I recommend you to read. If you have a hard time finding them, please do send me an email, and I'll make sure that you guys get a copy. I remember the day in 2015, RSNA. This is the big radiological meeting in Chicago every year, the year after Thanksgiving. I was looking at this presentation on why thyroid surgeons are frustrated with radiologists, and I couldn't help but chuckle, because I truly believe this is truth. Many times, the radiologist or the radiology team is not aware of the whole picture, and if you don't know the information that the clinician and the surgeon needs, you're never going to provide it. So we need to have teams of endocrinologists who understand radiology, pathology, nuclear medicine. We need radiologists who understand endocrinologists, surgeons, pathologists. We need pathologists who understand all the basic areas. And then we need to have what we call transdisciplinary teams. In a transdisciplinary team, everyone is going to have a baseline amount of knowledge. Everybody's going to know the basics. And then you're going to have experts in your particular field. Please report by the levels of the neck when you are talking about lymph nodes in ultrasound. And as I said, you must always, I cannot stress enough, check for the lymph nodes. Every single neck ultrasound should include sometime check for the lymph nodes. Many times when the clinician orders a thyroid ultrasound, the tech will only take a look at the thyroid, and they will make a beautiful poem on the thyroid nodule, which is important, very relevant. But sometimes they don't even take a look at the lymph nodes. It's always important to take a look at the lymph nodes. And then when you see 1,000 necks, 2,000 necks, then when you see an abnormal lymph node, it will pop up. You will understand what is abnormal. You may not know what it is. You may not know the final diagnosis, but then you can say, this is an abnormal lymph node. Most of the times, the abnormal lymph nodes may be completely hypoechoic. This means that they're going to be kind of like dark, very dark. They will lose the hilum. There's not going to be this white stripe in the center of it. And then you're going to have peripheral vascularity, which is not usual in a normal lymph node. If you have the chance, the opportunity to use elastography, it doesn't matter if it's a strain or shear wave, the lymph nodes in the neck that are abnormal may be rigid. But if you had to bet, there are two really relevant things regarding an abnormal lymph node that scream metastasis from thyroid cancer. And those are microcystic degeneration and echogenic foci. This is really important. And we're going to be talking about microcystic degeneration because it's really relevant when you do an FNA or a thyroglobulin washout. Okay, so let's take a look at an example. This is a completely hypoechoic lymph node with peripheral vascularity. And if you use elastography, this is on the rigid side. completely abnormal. So very different from the first ones. This is another relevant paper that I invite you to read. Echogenic foci, these are the bright dots that you can see in many patients with metastasis from thyroid cancer. Again, peripheral vascularity and elastography, it's black. Then this patient also has microcystic degeneration, really important peripheral vascularity. This screams abnormal lymph node. And as I said, this is a patient with N7 uh, metastasis from a papillary thyroid cancer. You can see the bright dots, the echogenic foci. You can see peripheral vascularity and some areas that are a little bit more rigid. When you are talking about N7, elastography, particularly strain elastography, may not be the ideal tool because since you have to compress in N7, you cannot compress that much. So if you were going to use elastography for N7, I would recommend that you use shear wave elastography, not particularly strain. This is another relevant article that I recommend that you read. And again, as I said, pictorial essay, we're going to be seeing hundreds of images of lymph nodes. You can see that the borders of this node, of this lymph node, are irregular, like lobulated and irregular here. And then you can see the peripheral vascularity, and these are completely rigid when you use elastography. By the way, elastography, if you have it, use it. But if you don't have it, don't think that you truly need it. One thing that I always like to address when I'm teaching neck ultrasound is use the ultrasound that you have. You don't have to have a premium machine. What you need to have is premium knowledge. Premium knowledge with a good machine is gonna take you far away. Always, always take time. You cannot address this in 2 minutes. Always have the patient with the neck hyperextended. Always take a look at the clinical info beforehand. And then sometimes when you see these like lymph nodes that are close together and they have echogenic foci, always think, could this be thyroid cancer? Sometimes if you were to take a look only at the top image here, you could think, is this a granuloma or is this an abnormal lymph node? For the most part, granulomas, post-surgical granulomas in the patients with thyroid cancer are going to be more anterior, are not really going to be deep in the neck. There is a very interesting article published in the Yellow Journal, the AJR, the American Journal of Röntgenology, that says that you should think of an area of interest when it's more than 6 millimeters and that it has vascularity in the periphery and bright echogenic foci. I think that size threshold, it's a little bit off because you may be able to find things that are a little bit smaller. So always come into the scan room knowing the thyroglobulin of your patient, because it will make a difference if you have that information. If you know when the patient had the surgery, if you know what the ablation dose he or she had, if you know the timing on the surgery, and I must always say, who operated, because some community surgeons do not have the best results or may have complications. This is another case of elastography. So I'm going to tell you a little bit something about shear wave elastography. When you're using shear wave elastography, basically what you're going to be doing is you're going to be pressing a button from the probe. One wave of sound is going to create the image that you're going to be seeing on the screen. And then another wave of sound is going to go through the area of interest. And that's going to be the one that the machine measures the speed of transmission through the area. And you can have results in two different ways. It can be measured in meters and seconds, as it's mostly done in the United States, or kilopascals, as it is done in Europe. And then you compare let's say, the muscle and you make a ratio compared to the area of interest. Always remember as well that when you're scanning a patient with thyroid cancer, they could have metastasis from thyroid cancer, but they could as well have many other diseases. I always tell the patients, the residents, particularly the people in training, that if a patient has bilateral lymph nodes that pop up like a Christmas tree, wonder if it's really thyroid cancer, because many times it could be lymphoma or could be any other diseases, perhaps tuberculosis. It is not something that we see every day, but it has to be in the back of our mind. Particularly in Mexico, we don't have sarcoidosis as much as it is prevalent in other areas of the world, but also it is differential diagnosis. So we can see here another irregular borders lymph node with echogenic foci, a peripheral vascularity, strain elastography says it is rigid, and then you go in, and then we did a biopsy. This particular one, as I can see through the bright spots, it's 4 needle biopsy. We use a small 20G needles. If you are going to be doing, if you're going to be performing neck biopsies, don't use core unless you really know what you're doing, because if you're not very familiar, you could be damaging the patients. There's a very specific kind of needle that is called a no-throw, that it's a little bit safer for those who are beginning. I know in Korea it's widely used, but for the most part, we stay out of it. We can do it when it's needed, but we stay out of it. Another important thing, and this is perhaps one of the reasons why I don't usually say metastatic lymph node, but abnormal lymph node. Sometimes the patients can have a baseline disease that can be rheumatological, or they can have thyroiditis. Patients with thyroiditis are going to have or can have abnormal lymph nodes in the neck. So let's take a look at some examples. This is a patient that at the time of the initial ultrasound, it wasn't known that she had a Hashimoto thyroiditis, and this was biopsied, this area here, and this patient in the left lower pole had this lymph node that looks kind of like irregular. It's hypoechoic. It doesn't have the hilum. So we thought it could be a metastasis, but it turned out it was Hashimoto thyroiditis. With time, this is the initial image, and this is 1 year and 2 years post diagnosis. This is another lymph node in a patient with Hashimoto thyroiditis. Yes, it's hypoechoic. You cannot see clearly a hilum, and it has some peripheral vascularity and some areas that are of interest through elastography. This is another neck ultrasound in a patient with Hashi, and you can see the bright areas. That's when you see those linear areas in the thyroid gland, you can think of Hashi as well. Very hypoechoic. You don't really see in this one, this particular image, the hilum and some areas of elastography that are a little bit rigid. Always Hashi again. Look at the periphery of this node with lobulated and irregular margins. This is also Hashimoto thyroiditis. Then again, as I said earlier, not everything in the neck of a patient with a thyroid cancer will be thyroid cancer. This patient had thyroid cancer, and then we found this abnormal lymph node that has lobulated margins, hypoechoic. It doesn't have the echogenic hilum. It's very rigid with the strain elastography, and we did a biopsy, and it turned out to be the metastasis from a poorly differentiated squamous cell carcinoma. So always, that has to be in the back of your mind again. Patients with renal. These kind of patients will also present with abnormal lymph nodes. They are a nightmare for the surgeon. And I can say today that they are also a nightmare for the radiologist. Look at this lymph node. It's hypoechoic, some peripheral vascularity, and loss of the hilum. So far we can say that the ultrasound for the lymph nodes is extremely relevant, particularly in those patients who are going to be enrolled in active surveillance program. Sonographic findings will impact the intervention, the prognosis, and the final outcome. When in those groups that do have active surveillance, you must have a very good team. The people who does the imaging will always have to be the most specialized. You have to have very clear ways to measure the lymph nodes and the nodules. No matter what happens today, it doesn't matter if we have advanced CT, MR, NUCs, ultrasound remains the most important imaging modality for the patient with preoperative staging for thyroid cancer. And as I said earlier, we don't need a premium 100,000 machine in order to find an abnormal lymph node. What we need is premium knowledge. These are images from a machine that may be 20-year-old, and you can see that there's some cystic degeneration. Always think of metastasis in the setting of a patient in the follow-up with thyroid cancer. I'm going to stop here 1 second, because when we do FNA in these patients in order to document the disease, many times what you will get a liquid, like a brown liquid, kind of like oil, they say. And the pathologist is going to report that they don't have abnormal, or they don't have cells. But that's really relevant, and that's why we also need to do FNA washout of thyroglobulin. Basically, what we do is when we took the cytology sample, we also wash our needles in 1 cc of saline, and then we send that to the lab. A couple things that I always address: you have to let the lab know that you're not measuring thyroglobulin from blood, because they're gonna call you and say, "Hey, you know what, Dr. Alvarez? Thyroglobulin is measured in blood, not in this particular." So you have to talk to them in advance. The earlier that they can perform the exam, the better. And they also need to report it without the reference values, because this is not from blood. And the reference values are going to be different from a FNA washout than from the regular measurement of thyroglobulin. One of the things that you're going to be seeing in the lexicon of the iThyroids 2023, that I don't know, perhaps we're going to be seeing the first results 2025, 2026, is that it does talk about the lymph nodes, and that's something really, really relevant. That's something that is not very much addressed in the ACR 2017 guideline. So the surgeons will have this kind of patients that has had 2, 3, 4 surgeries. This is not an easy neck to scan. This is not an easy neck to operate on. And as I said earlier, when we find an abnormal lymph node, we can find a safe area to enter. Many times I try to avoid the muscles, because when you go through the muscle, the patient is gonna have some discomfort. So if I can avoid the muscle when I'm doing an FNA in a lymph node, I'll do it. Another relevant thing: when you are doing the FNA washout for thyroglobulin measurement, there's something that is called the hook phenomenon. The easiest way, and this is perhaps an oversimplification, but it's very easy to understand. When there's too much thyroglobulin in the 1 cc fluid, then the machine may say that there's no thyroglobulin. That's why, in order to avoid the hook phenomena, we also do the washout with 1 cc and 5 cc's. But that's rare, but it does happen. Okay, So what we need in medicine is to minimize morbidity. There are many times that we will find things that perhaps will not necessarily need to be addressed right away. Always keep on the literature. And another relevant thing is those who perform procedures with neck ultrasound, interventional procedures with neck ultrasounds, will have complications. If somebody tells you that they perform procedures and they do not have complications, there's only three things going on. They don't do procedures, they don't realize they have their complications, or they're lying to you. So you can have a puncture in the blood vessels, which in a particular setting, like if you happen to do a fistula between the carotid and the jugular, it's disastrous. So always keep an eye. Have these kind of procedures performed by the person who has the experience and the training. This is a puncture here to the jugular. You just need to compress a little bit more, but it does happen. One of the things that I say, people in lectures don't say that they have complications. We do every once in a while. This is also another relevant article to read. And as I said earlier, you have to scan 1,000 patients in order to understand what is normal. And then when something is abnormal, it will automatically pop up. Ultrasound is good for the follow-up, is good for the diagnosis when we do FNA. When we do FNA, tip. When we do FNA of a lymph node, we don't use capillarity. We tend to use a 22G needle and we aspirate. That's different than when you do the FNA on a thyroid nodule, because many times you can do capillarity. In the lymph node, aspirate, always aspirate, and then you will have most of the times a good sample. So what's coming? Or not, shouldn't say what's coming, what's here. Some places in the world can also perform for metastasis in a lymph node. Laser ablation, it's not used widely, and I think it's going to be replaced by RFA ablation. But we can also perform some other types of ablation. We'll talk about those in a minute. Particularly, as I said earlier, when you are in the setting of active surveillance, ultrasound will be your primary imaging modality, and you always have to keep an eye on the increase in size and really relevant, have accurate, consistent, and reproducible measurements. Always have an experienced sonographer perform the exams. Get up, stand up, scan your own patients. Always, it's really relevant to look for extrathyroid extension and look for abnormal lymph nodes, suspicious for metastasis. So we're gonna move to the next slide because this is something that I really want to talk. So early in the month, we had the second NACID meeting in Sarasota, in Florida, the North American Society for Interventional Thyroidology. And one of the things that I noticed is that many people were talking about how they do RFA on lymph nodes for neck metastasis, for thyroid cancer metastasis. One of the things that we've been using in the past 5 years is polidocanol, which is this particular medicine. We do inject it in the lymph nodes. We always go to the back of the lymph node and start with 30% volume of the 30% of volume of the original volume of the lymph node, and we inject it from the back, always from the back to the top, kind of like a moving chop technique when you're doing RFA. And this is extremely, extremely effective. I know ethanol has been widely used for over 20 years after the experience reported in the Mayo Clinic. But we found that lauromacrogol, polidocanol, it's cheap because it's less than $100, and this $100 is for 5 doses. So keep an eye out, because I'm sure we're going to be seeing more of these very effective and low cost solutions, alternatives. Always, as I said earlier, remember to scan N7. The first surgery for a thyroid cancer patient has to be the best surgery. And preoperative staging with ultrasound is going to be super relevant. This is a 15-year-old girl in whom the initial exam, the initial ultrasound, had not found these metastases, proven metastases of the cancer. Always scan N7. If that's one thing that I really want you to remember. This is another patient. We can see the echogenic foci. It's elastographically rigid, and we go in. Many times, I try to go in through midline, but that's a different talk. Anyway, take-home messages. Advanced ultrasound has a central role in the staging and follow-up in thyroid cancer. As I said earlier, when needed, the first intervention should be the best intervention. And in order for the surgeon to do that, she must have the best ultrasound, the best sonographic information. Advanced ultrasound must provide reliable information, because this is the only way that the surgeon will do the right thing the very first time. So this is my email. Feel free to WhatsApp me or email me, and I thank you for your attention.
Terrific. Thank you very much, and really a wonderful lecture, and always appreciate the opportunity to hear what's important for identifying abnormal lymph nodes. We have one question from the audience that I'd like to pose to you, and it has to do with abnormal lymph nodes and Graves' disease. Does that pose a challenge in diagnosis for you?
It's a really interesting question. Patients with Graves' disease and also some other rheumatological diseases can have abnormal lymph nodes. That's exactly one of the reasons why we don't say metastatic. We're talking about the setting of a patient in a follow-up with thyroid cancer. We don't usually say lymph node with metastatic disease. We say abnormal lymph node. And this warrants that you have to correlate with the clinical and the lab findings. And as I said in the beginning, always take your time. Take 2, 3, 4, 5, whatever time is needed in order to read about the patient that you're going to be scanning. If you do that, it will pay, because you come in. This is a philosophical comment. Imaging has changed from radiology. Radiology in the 20th century was dominated by radiologists. Imaging in the 21st century will be dominated by those who have the experience in imaging sciences and the clinical information. This, coming from a radiologist, this is really relevant. I believe that the radiologist must involve in the clinical setting, must know more about the patient, must talk to the patient, must talk to everyone in the team. It is only when the radiologist understands the information that he has or she has to provide, the relevance of that information, that he or she will do the right thing. So Graves' disease, no, I don't think it's a difficult thing, because you will say abnormal.
Okay, so let me engage our panel here. Dr. Khorsandi, what do you think the role of other modalities of imaging play in the workup of thyroid lymph nodes, thyroid cancer-related lymph nodes, CT, MRI? When do you recommend that those be obtained?
So, God, I have a lot of questions and a lot of comments. In regard to that, especially you showed a patient of a 15-year-old we have to address the retropharyngeal lymph nodes. And I think that's where our downfall is going to be if we diagnose. And as far as I know, with ultrasound, we cannot see them, we cannot diagnose them. And if at the time of first surgery, as you emphasized, if we miss that, that's going to be the pitfall. And that's where I see a role for CAT scan. For MRI, my personal experience, I don't really like MR for thyroid cancer diagnosis, particularly because at the cervicothoracic junction, there's a lot of artifact because of the patient's breathing and slice thickness. So that's not my my modality of choice, but I would use CT. So that's the question you asked, but I do have a lot of questions for Dr. Alvarez. Particularly, I want to find out, you did say you do use polydocanol.
Yes.
Do you have any results? What happens to those lymph nodes? You know, in United States, we do use polydocanol for treatment of varicose veins. I would like to know how you came up to polydocanol for treatment, and what is it that were the lymph nodes then resected? What did it do to the thyroglobulin level? All of that stuff.
Yes, the preliminary reports have been presented at the ACE meeting. It's a promising technique. You have to be resourceful in Mexico. You have to think that we have limited resources, and that was the mother of our I don't want to say discovery, because this has been used in other places of the world, particularly in Asia. So we came up with we read a paper there, and we realized, well, this is something that they've been doing. Ethanol is very easy and very cheap to find in Mexico, very easy. Whereas in the United States, I know recently it's expensive and difficult to find. But to be honest, if you don't do it right, the patient will suffer. And not only that, I believe that the surgeon will remember me when they have to go in because of the fibrosis that it creates. One of the things that we've noticed with polydocanol is that the thyroglobulin levels completely negative. They go to pretty much zero if it's one nodule. And the patients who have had to go to surgery, they haven't had fibrosis. I can definitely share some of the papers, preliminary papers that we've seen.
Dr. Shaha, thank you. Let me just ask you a question. In the surveillance setting, there's a lot of information that can be gleaned, but oftentimes it's not actionable information as it relates to a patient's disease process, but may be the cause of significant anxiety. Do you want your ultrasonographer to report every suspicious lymph node, if regardless of their size, or how do you balance the acquisition of information and the implications for whether it's clinically relevant?
I think that's a $1 million question, and you need to develop a relation between the surgeon and the radiologist. And it is not uncommon that many new radiologists will give the whole long description, which patient reads on the portal and gets very excited or finds it very difficult to interpret. And then they call us, and it is very difficult to revise the the final report. So what we have done is we have developed a system here where it is somewhat, if I can use the word, standardization of the reporting. Whether you use the TIRADS or you use your own standardization, or you go through the checklist, suspicious lymph node, etc. Generally, if the lymph nodes are very tiny, we ask them not to comment on being benign or malignant. Because once they write, there is a 5 millimeter lymph node, suspicious of metastatic cancer, the patient and the family are going to push us for needle biopsy. And the worst is, we get pushed into doing a needle biopsy, and then they insist on doing a surgery. So our philosophy has changed. Anything below 1 centimeter, try not to aspirate. Because even if you decide that you want to operate, it is not uncommon. 50% of the time you won't find the disease. I'm talking about reoperative. I'm not talking about primary surgery. So I think our philosophy has changed quite a bit. Finding lymph nodes in patients with thyroid cancer is a commonality. They live with it, they grow with it. And Mike Tuttle and ourselves, we wrote a paper about active surveillance for the lymph nodes. And only about 10 to 15% increase over a period of 5 years. So that is not an unreasonable approach to monitor the lymph nodes unless the lymph node is in a very critical area in the cricotracheal region or plastered between the thyroid cartilage, between the trachea and the esophagus. Those are different. And that's where you as a surgeon need to evaluate both the ultrasound and cross-sectional imaging. And the cross-sectional imaging, which helps best, as Azita mentioned, is CT scan with contrast. I would go ahead to say, don't be shy to get a CAT scan with contrast, both pre-op and in the follow-up if you find something abnormal.
So what's your threshold for ordering a CT scan in a patient who's presenting with a newly diagnosed thyroid cancer?
Me and my few colleagues at Memorial, we would always do a CT scan with contrast pre-op. Look at it very critically ourselves, have the interpretation be given by the radiologist, and have that image during surgery to see pretracheal, paratracheal, retropharyngeal, high retropharyngeal lymph nodes, etc. So the threshold, almost all the patients get it. I think,
Really?
as Marco mentioned and as Azita mentioned, do the best first operation. And to do the best first operation, do the best first evaluation.
Okay, terrific. Marco, can you tell me how good are you at looking at a positive metastatic node and assessing for extranodal extension?
Well, that's a very good question. Ultrasound will be excellent for lateral nodes, but for central nodes, it's not that good. Specificity and sensitivity in the central area of the neck will be anywhere from 30 to 60% accuracy. But in the lateral neck, you can go all the way to 95, 100%. So we're very good in the lateral neck and so in the central neck. That's where cross-sectional imaging really does help.
Azita, can you comment on that?
I found it in the central compartment in the way it.
Is there something else I can help with?
Oh, it's your Alexa.
Sorry.
It's done that to all of us. So I find that actually my surgeons, the thyroid itself, so the thyroid gland for evaluation of extrathyroidal extension, I prefer ultrasound actually. I think it does a much better job with the soft tissue surrounding it. However, having said that, the interface with the trachea, the interface with the esophagus, I think the two studies are complementary. I can't just say ultrasound does a better job or CT. In central compartment, I would say I can't, again, it's complementary. I find CT and ultrasound complementary. And if we lived in an ideal world with unlimited resources, I would reflect what Dr. Shah said. I would do a CT and I would do ultrasound. The other thing is the level 7 lymph nodes. I find it very hard. I don't see our ultrasonographer picking up those lymph nodes unless they're, as you said, they're in tune to picking those up, because I think how do you get around the manubrium and all the artifact? And I think that's another area where CT, I think, is very helpful. Because a lot of the lymph nodes, once you get below level 6, I find the surgeons, a lot of these people, especially with the central compartment lymph nodes, they end up having paratracheal lymph nodes extending into the mediastinum. And again, you want to do your first clean operation.
Great. Marco, and maybe I can follow up with Dr. Shah. What do you see in lymph nodes that have been treated with radioiodine? How do you assess those, and do they look different when you do follow-up ultrasound?
In the acute settings, yes, they do have changes. They become hypoechoic, but with time, they go back to pretty much normal. They should be followed up as every other nodule.
And the appearance should normalize to what appear the appearance of normal.
The appearance does normalize. A patient who has had who has had iodine in the long run will have normal lymph nodes. It's in the very acute setting that they do change in the first months, like I would say 3 months.
Great. Could you comment a little bit, maybe Azita, on elastography? We often don't get that. Ashok, do you get elastography?
No, I think it was very popular in Singapore, and then it came to United States for a short time, but I don't think our radiologists have used that consistently. But looking at Marco's pictures, I think it is very impressive.
No, so at Sinai, we use them for liver, but I know they use them, supposed to be used for breast and for thyroid. Your images were impressive. Honestly, we haven't done it. It's something that I thought of after listening to you that I would like to try, but we haven't used it either.
May I say a couple comments?
Yes.
Just briefly, very brief. Two really relevant things that we're going to see in the future of lymph node imaging in the setting of thyroid cancer patient. We're going to be seeing artificial intelligence. That's one coming. And the other one, we're going to be seeing the use of genetic markers obtained from FNAs in the setting of thyroid cancer patients. So those are two areas that in the next person who gives this lecture, I'm pretty sure they're going to talk about this.
Great. We have one or two comments coming in. I'd like to just make sure in terms of the use of ablative therapy for lymph nodes, what's your criteria? Are you for using non-surgical but rather ablative therapy? And I'd like to bring that back to Dr. Shaha. When do you refer patients for that mode of treatment here?
Very rarely, because I think as a surgeon, I can make a decision when the patient needs operation. I can make a critical decision that these lymph nodes can be monitored and observed. The only time I would refer a patient for either alcohol or I think the experience with RFA is so minimal that I'm not going to comment on that. But for alcohol, I think many patients used to go to Mayo Clinic and had some remarkable results. I can't deny that. I think those are the patients where we have done 3 operations in the central compartment and there is still a lymph node. I feel very humbled and unhappy both. And I don't want to operate there because I'm worried about the functioning nerve. I think I will send the patient to Mayo Clinic. Hopefully the patient will never come back.
Okay. Marco, how about you? What are your criteria for using, it sounds like for using a ethanol ablation with this material that you referred to. What's your criteria for that?
Okay, we stopped doing ethanol about 5 years ago. We only do polydocanol today. We have to have rising thyroglobulin levels. We have to have a documented abnormal lymph node with either a cytology or a FNA washout. And we have to have we need to make sure that those are the only areas, let's say 1, 2, 3 lymph nodes. If more than that, then it's like cherry picking in surgery, and it's no point. It has to be very focal in order for the patient to benefit. And many of these patients, because it hasn't been said, are patients who are not surgical candidates because they do not want to have a surgery, because they are anticoagulated, because of any other health issues.
Okay, Ashok, I'm going to end with one final question for you because it's piqued my curiosity here. on the use of CT for all patients with diagnosed thyroid cancer. Certainly, and kind of the mantra has been patients with bulky lymph nodes, with concerns for invasive disease. What do you think, in the absence of those findings, what do you think the yield is that influences your surgical management for patients who don't have bulky nodes and don't have suspicion of invasive disease?
I don't have any prospective data, but I agree with you. Below 2 centimeters, it is very unlikely to help if the ultrasound does not show any lymph nodes. But remember, I'm a surgeon. I like to get a good image. I want to see where the tumor is. I want to see, is it in the posterior portion? Is the posterior capsule broken, etc. So to me, it helps as a surgeon, but I'm not going to argue below 2 centimeters, it is a must. But I think more than that, also you have to realize the sensitivity of the central lymph nodes with a good ultrasound, even with the best ultrasound, is not as good. And I would add one more thing. In medullary cancer, the lymph nodes are in the paratracheal area, deep superior mediastinum. Level 7, if I can use the level 8 lymph nodes. And those you will be able to image better with a good CT scan. We used to have always a fear not to do the CT because of the contrast. But you know that the 2015 guidelines kind of said, hey, by the time you're ready for RAI, it is washed out. The whole iodine is washed out. So it doesn't make any difference. So as a surgeon, if you get a better information and you think I can do a better job, do a CT scan.
Terrific. Listen, we are pushed up against the 9 o'clock hour. Dr. Alvarez, Dr. Khorsandi, Dr. Shaha, thank you so much for joining us, and I really appreciate it. I think we will continue this discussion on non-surgical management next week, March 1st. We invite all of you to join us, and look forward to that presentation. Thank you all. Everybody stay safe, and appreciate your tuning in.